was able to reduce my generic drug costs by 90%. And, part of what Dave's been so vocal about is that healthcare it's bankrupting people and organizations and communities and taking all this money away and diverting it from family things and education and housing and communities and schools. And so, from a big picture perspective, something went very wrong.
Welcome to the Only Healthcare podcast. Joining us today are two experts in the mission around looking at healthcare change and system change. David Chase, who's co-founder of Health Rosetta, an organization redefining how benefits are delivered, and Steve Ditto, compliance advisor and a founder of Ditto and Associates, who brings a critical patient-centered and legal perspective to healthcare transformation. So let's dive in. I'm going to ask David and Steve to introduce themselves. So David, you want to start?
Yeah, as you mentioned, I'm with Health Rosetta. I'm one of the co-founders. The quick background, professional, and there's a whole personal story if you want to get into that. But I started my career in Accenture's healthcare practice, then went over to Microsoft back in the day when they were getting the enterprise. What I was most known for there was starting their healthcare partner ecosystem, which I've been out of there 20 years. So there's been a lot of other people who've contributed to that. But today it's about a 28,000 partner, $30 billion ecosystem for Microsoft. As I mentioned, I left there, did some startup work, and then came into this arena, which even though I was in health tech, health plans, health insurance, it's almost like a completely different industry. And I dug into it because of, some things that I saw that, had impacted some people around me. And that was really what brought me back to healthcare, because I was out for over a decade.
Yeah. Hey, Randy, thanks again for having us on. So my background is I've been in healthcare for 30 plus years, generally as a technology consultant. Like Dave, I was at Accenture and EDS and HP and a variety of consultant and technology firms. With the last 10 years has been kind of the through line is how do you use analytics to deliver higher quality, more cost-effective care? And I've done that with health plans. I've done that with employers. I've done it with a whole range of providers ranging from emergency medicine, chronic care medicine, most recently surgical care medicine. And, you mentioned a little bit of my patient focus. My entire career, I was like the best health plan member ever, right? Never used my benefits, never went to the hospital, never had a procedure. And then 3 years ago, all of that changed. And, as my doctor likes to say, the warranty ran out. And I got an autoimmune condition, which was really hard to diagnose, even harder to get treated. And, I saw and used way too many of my benefits and, wound up taking a bunch of really expensive J-code drugs in the hospital, which put me even deeper in the hospital, the ICU. So I got to see that route for a while. And then, I wound up getting some home administration. And now I'm better. I'm in remission, but I'm on 7 generic drugs. And so I'm, began seeing why are they so wildly overpriced based on what you can get in the market? And why is there so much variability? Why is Optum, who is my healthcare provider, charging me X? You could get maybe a little less than that on GoodRx. You could get maybe 50% less than that from our Cuban, and you could get 90% less than that by paying cash at an online pharmacy. And so, I really wanted to do something about that. And where I got really lucky was about a year ago. Dave asked me to be on a panel at his Health Rosetta conference in DC, talking about the patient perspective, talking about these things to a group of advisors on what they could do to help their employer clients do a better job of lining up benefits. And I guess the conclusion I came to was that I really do think employers can make a difference. And they provide the healthcare for about 50% of Americans. And if they embrace their fiduciary duties and had better compliance, they could have better benefits at lower costs and healthier employees. And that is now my mantra. And how do we bring that to a bigger audience than just me being a one-on-one patient advocate?
Good way to kick this off and start talking about this whole idea of how do we begin to address system change and why system change. We have a lot of new players, particularly on the employer side, but also in the brokerage, manufacturers, and so forth in the ecosystem. But what I'd like to get a better sense of, and kind of a brief snapshot from David and then Steve again, what was the moment or insight that really made you realize that system transformation was necessary?
Yeah, for me, it was a friend who'd had a similar career path to me, and she got the wrong cancer diagnosis. That happens 1 out of 4, 1 out of 5 times. Of course, that led to the wrong treatment plan and destroyed her physically, financially, emotionally, leaving behind a 10-year-old daughter as a single mom. It was like, that was brutal to watch. And it wasn't like there was a single bad doc, it was a system failure. And, the way I was raised, you see a problem, you don't do something about it, you're complicit. So that's what really brought me into this space. And it's so different than the rest of the industry. And you realize, what's a health plan, right? It doesn't provide any care. It's just a bunch of legal documents that govern everything. And every dysfunction that I've ever seen in healthcare, not one of it is an accident. It's all codified in those agreements. And so just basically put us on a mission to see how we could fix that. Obviously, a $5 trillion industry is not an easy thing. So, studied social movements, revolutions, new product category introductions, right? These are the types of things that give you some shards of approaches that you could take. And, we can talk about that, but that's basically what really got me into this arena.
And Steve, you kind of alluded a little bit to what drew into this, but what was the big picture moment for you?
Yeah, so I think the catalyst maybe was, as I mentioned, I was able to reduce my generic drug costs by 90%. And part of what Dave's been so vocal about is that healthcare it's bankrupting people and organizations and communities, and taking all this money away and diverting it from family things and education and housing and communities and schools. And so, from a big picture perspective, something went very wrong. And I guess maybe the conclusion I came to was, when I was in the industry 30, 20 years ago, things like PBMs seemed like good value adding exercises, companies, organizations, right? Let me help you get the right drug at the right price and deliver it to the right person. Now, what I've discovered, I guess, through my own personal journey, is that is not the case at all. And it is very much a case of, there's these very opaque organizations that are designed to extract, not create value, but to extract value at every point in the chain. And they're doing it through, what I view, particularly from the employer side, as lax compliance is leading to poor procurement. It's really been head shaking for me. I've actually spent a lot of time in supply chain, predominantly on the technology side, but I've seen really large, sophisticated companies bring a tremendous amount of capability and insight and rigor and prudence and discipline to that process. None of that is being applied on the healthcare side. And so you have these highly conflicted brokers and these self-interested vendors coming together and, effectively, I'll say misleading, but it's probably lying, ultimately to employers that, they've got the best deal out there and this is industry standard and there's nothing you can do about it. And so just, happily, willingly accept that 10 to 20% increase every year, which is fine until, the frog is boiled and it finally realizes that they've destroyed the economy in the process. And that's what we're looking at. And that's kind of what I discovered.
You made an interesting observation about PBMs, and I'll validate it for you because it's almost a 360-degree situation. But the PBMs did do a good job in the early days. It was very simple, 3-tier formularies, minimal discounts, but the drug prices were very in line, right? So it was really more about, to your point, managing that. And back in those days, believe it or not, 3 of the major drug companies owned their own PBMs. And they divested, and now the PBMs, oddly enough, own their own drug companies, right? They're making biosimilars and saying you have to use our biosimilars. So it's really incredible how that whole thing has shifted. And I think to your point, purposefully they started out with the right idea, and now they're in a really tough situation. I think they've put themselves in. But I wanted to ask David too. I know you talked about common sense healthcare and making a change based on a moment that you had in your life with someone that you knew. What does the change look like, right? So for Health Rosetta, like what are the types of things you're implementing to actually make that impact and get people to change the way they do things?
Yeah, I mean, the Rosetta name is basically just riffing off of the idea, the Rosetta Stone, right? It helped decode these indecipherable Egyptian hieroglyphics. And in healthcare, the health plan contracts are the equivalent of Egyptian hieroglyphics. And so basically, people are problem solvers everywhere in the world, right? No matter how much resources, maybe they have some limitations. I was like, there's people who've cracked this code. So I just went digging around as a, quote unquote archaeologist. And so we don't claim to have invented anything. What we have done is found the people who've cracked the code. And I did a TED talk on one of them. They've been doing it longer than anybody else I found. It went from a 500 to 5,000 person hotel company in your state, Michael, and cumulatively have saved $540 million. So what we did was like, okay, what is going on there? What are the common threads across these organizations that have succeeded? And it's pretty straightforward. It's a lot of the complexity is by design in our industry. And you think about what should a plan be? Big picture, make good decisions free, make bad decisions expensive, right? That's a good design principle. And then also design it like a good parent, right? They help nurse you back to health when you're not feeling well. They kind of keep you out of harm's way, when you have some great idea that maybe it's not that great. And that's what we do. So what does that mean? Starts with great primary care, right? Not a state secret. There's no well-functioning healthcare system in the world not built on primary care. One of the books I wrote was on the opioid crisis, of great oversimplification, but really the essence of it. If we had not destroyed primary care in this country, we would not have at least the first 20 years of the opioid crisis. And so that's foundational. Rose and Hotels is the company that I did the TED talk about. And they're, no offense to you, Michael, but you're in the state that has the highest percentage of price gouging hospitals. It is not an easy state to succeed, and they had a very significant disease burden. Despite that, right, they saved all this money. So that's number one. Then get better, follow the money, right? Where is the big spending? Well, it's things like premature deaths or births, rather, cancer, and so on. And so you have smart approaches there, and that's usually a different type of contract. I mean, all a PPO does, maybe it's like PBMs. They probably made sense. They probably added value right now, but PPO networks should be in the Marketing Hall of Fame as the biggest value extraction enablement device is perceived as their greatest value. And so we see all the time the all-in cost of a surgery, you name it, surgeon, facility, you name it, can be less than the cost sharing component in status quo plans. So that's a big part of it. And then obviously what we're talking about here, pharmacy, the pharmaceutical piece of it has become a bigger and bigger percentage, and it's become a bigger and bigger racket. And so, the good news in air quotes, the shenanigans are so extreme. We've seen up to 50 different revenue streams that PBMs have created for themselves that you just seize control, to Steve's point, of the procurement process, which you do in every other area of your business. Whereas healthcare is like, it's been supply driven. The industry's like, here's our stuff, take it or leave it, make a decision. That's not the way to do this.
You're saying because they're coupling the plan with the PBM, you don't have any way to carve that out, or they don't know how to ask to carve that out.
Don't know how to carve it out. They don't think there's any other options. And as Miss mentioned earlier, there's been some conflicted advice. So you get that, and that's the most common touch point for most people in the healthcare system is the pharmacy supply chain. And so you can start to build that awareness, that confidence. And rather than plans that have crushed high value community pharmacies, we advantage those. They're great. They can, pharmacists can add tremendous value. And then, so like, those are the big pillars. There's some other things, like one of the other big things that I've seen really work well is nurse navigators, right? They have this blend of clinical and humanity that can build trust. It's the most trusted profession. And if they're not financially conflicted, people trust them, and you build up this ladder of trust. Oh, Bob got a free lab. Sally didn't have to pay anything for MRI, because guess what? Most companies would rather pay 100% of 500 than 80% of 5,000. And then ladder up, surgery, specialty drugs, right? And people understand you can turn waste. Now, we've known forever 30, 50% of spending is waste. We can turn that into prosperity. And that was a big part of that TED Talk. Like, they've saved so much money, they can afford to pay for their employees and their employees' children and the nearby neighborhood full college education. Like, how many employers are doing that? You can imagine how great that is for their competitive advantage in recruiting and retaining talent.
But Steve, same thing. Like, you're applying similar strategies to the clients that you have.
Yeah. And so my focus, I guess, has been, kind of twofold. The first was employers need to embrace their fiduciary responsibility. And before I got sick and when I was consulting, I don't think I had ever, heard ERISA. I don't think I could have spelled it. But when you look at it, it's interesting. It is good business. It's not overextended regulation from the government, right? It's like, hey, you need to make prudent decisions. You need to have disciplined processes. You need to have access to your own data. You need to have audit rights around, what's going on. And ultimately, all of that leads to transparency, and more transparency than is in the process. And so that was, kind of the first piece. So become a real leader through embracing your fiduciary duties. And then the second piece was, as I was looking at, okay, so how do we turn that into action, right? It's not just education. The action, the first thing that comes to mind, based on my experience, but I think also just based on, the ability to get benefits from it, is take this pharmacy issue off the table, right? And so when you look at the 3 or 4 big class action lawsuits, ERISA, CAA lawsuits that have come out, first big one was J&J, then Wells Fargo, and now JP Morgan Chase. They're all about, when you boil them all down, exactly what I just described, that all of those 3 or 4 large organizations are breaching their fiduciary duties, specifically around their pharmacy benefits. And there's an opportunity there for every employer to, instead of enriching the plaintiff attorneys, to take those benefits and, as Dave said, plow it back into their own company, into their own benefits, and to, creating strategic advantage, from those savings. And so one of the things that Dave and I are doing together, and we're launching at the next RosettaFest, is essentially what we're calling a PBM field guide. And there's a couple of components to it. One is education around all of this. And it's directed not only just at employers, but at the advisors, the non-conflicted advisors that are counseling employers, to really know as much as they can, everything they can around being a good advisor around pharmacy benefits. And a lot of it is, again, it's common sense. It's all these gotchas that we've been talking about, the common pitfalls, what really works and what do you need to do to get to a better spot. And then to help them get to a better spot, we're introducing a set of tools where we're really hoping to set the standards. And, Dave's middle model and guidance to me is, look to things like the AIA, right? The Architects Association that set the standards in construction. And now, so every construction contract out there uses standard definitions, standard contract terms. You take all the complexity and all the redundancy, out of it, and get everybody to agree to it. So we're going to have some standard definitions, some standard contract terms, a standard RFI, a standard RFP, some evaluation criteria that you can use to evaluate the RFP or the ecosystem that's out there. And I guess, part of what I would say is, and this is part of the perspective, is, you look at the conflicted PBMs, and the big 3 have about 80% of the market. The big 6 have pretty close to 94, 95% of the market. And so what we're really trying to do is to make it easier, safer, less risky, less costly, less everything, to be able to look at that other part of the ecosystem and to move your business from the conflicted ones, who we may never be able to, knock off their pedestal, but, give you some good alternatives so that you can make a decision, that you can get the benefits, and everybody can be the beneficiary of it. And so we're going to launch that in August, and, we hope to make a pretty big dent in how the industry buys pharmacy services.
Do you think the administration and what they're trying to do would create some disruption with the conflicted advisors?
It's hard to say. Some of the executive orders have certainly been, helpful in that direction. But then it's, dependent on the individual agencies to step up and enact those changes. And Dr. Oz at CMS has said things like, pharmacies or pharmaceutical companies, clean up your rebates or we'll have to. Like, will that really play out? Not sure. The person that's being promoted as the head of the organization that's responsible for ERISA, it actually has a, kind of a anti ERISA background, right? And so at least in terms of making it harder for employers to shirk their fiduciary responsibilities. So, how's it going to play out? I don't know. Here's my bottom line answer to you is don't wait for Washington, don't wait for the attorney general in your state. You have the ability, through a contract and a procurement process to choose who you're going to do business with and the terms under which you're going to do business with them. And, it doesn't matter what Dr. Oz thinks. Like, you were saying earlier, if you move to a focus on generic drugs, if you don't mischaracterize generics as specialty, if you can tap into some of the companies and drugs that have typically been off formulary just because they didn't play the rebate game, you can get, really good pharmacy benefits at a lower cost and deliver better clinical outcomes for your members.
Randy, if you can, and given on this topic, you had talked about with all of the challenges, there's a lot of feedback that you've heard that it creates really apathy right now, right? Where they're saying, well, maybe we'll just give a fixed amount of money to the employee and wash our hands of the benefits. Or, is that something, Randy, that you see as real?
I mean, that's one of the trends that is happening. Now, where that goes, nobody's really sure right now because of all the other changes that are happening. But from a business perspective, to both Dave's and Steve's points, if you're following good business principles, then you should be able, and there's plenty of money to be able to provide these kinds of benefits. And that kind of leads me to the bigger question in this, because there's been a lot of people like yourselves that have been working on this to try and to engage and transform the thinking of a lot of the business leaders. So the question is, why do you believe what you're talking about and where you guys are at will matter differently, particularly for the long haul, and particularly with the approach that you're taking, the RosettaFest that's coming up later in August, and so forth? Why do you believe that's going to work this time?
Well, it is working, which is the biggest difference. And so what we observe, we've been in the industry a while, really didn't have a dog in the fight. So we're not trying to protect this or that. And it's interesting that a lot of smart people who've read Clay Christensen's work on disruptive innovations sort of have this blind spot when it comes to healthcare. We're like, okay, yes, the healthcare sector, right? 180 million people get their healthcare through that, 54% of adults. Oh, if you're going to change healthcare through the employer side, you got to go to the jumbo employers. That's not how disruptive innovation happens. It's actually the mid-market. And so when we started out, we launched by RosettaFest will be about 8 years. And it was when my first book came out. And there were 5 companies or employers. There was some public sector too, and a union. There were 5 that I'd find in my archaeological dig. And basically our thought was, if somebody was saying what we were saying to me, I would have said, that is awesome. Good luck. Call me in 5 to 7 years. And so we really just put our heads down and said, you know what, which is where we're at now, which is if you had thousands of successes in every corner of the country, small employers, large employers, rural, urban, private sector, public sector, it's pretty hard to argue you got lucky. And so we are open book on that. And our theory of change, and this is also where it's different, the typical model on the business side of healthcare is you find some little market advantage. You get the new CPT code, you get this or that. There's some arbitrage opportunity and you hold on to that precious ring like Gollum, in Lord of the Rings. And that's it. Whenever you had a little success, it changed nothing. if you look at how you change industries, and basically the arc we've gone on is like, okay, here's the blueprint, here's the distribution channel, right? So we have these benefit advisors that are aligned, and directly they're responsible for 10,000 employers and about 5 million lives. Indirectly, we've had a big influence on legislation, but also these alliances of employers. Then we realized what you have to do, like any industry, we have this weird $5 trillion cottage industry that, is run by bubblegum and baling wire on the back end. Like, you need to develop standards to basically, we were all about repeatability and verifiability. Yes, the plans were way more effective, but the effort was way harder. Most organizations weren't doing that. So it was about repeatability, and then verifiability. And so we did some, technology development. We had that background, but ultimately, like, where Steve comes into this is, even if we are wildly successful, 10x our biggest streams in Health Rosetta, we are a public benefit corporation, which means we're a for-profit entity that has a social purpose. Our intent from day one, if we could prove this out, is we would open source this. This is how you disrupted, IBM and Microsoft, right? This is how Tesla has been disrupting and transforming the auto industry. And you open source that becomes, and you define the standards of excellence. That's how a new industry supply chain emerges. You've seen it in financial services, where the cost to transaction, an interest swap, has gone down 97.5%. So, and we have this performance lab of 400 employers that we've worked directly with in the trenches. We are not ivory tower folks. And we battle test things for 2 or 3 years. Then we make it available to all the Health Rosetta advisors, further battle testing. And then once that happens, we open source it. And so we announced we're going to do that 2 years ago at RosettaFest. Last year, we did the first tranche of resources, which is both kind of contracting, procurement, data use standards, and technology, because again, it gets pretty wonky. You have to get wonky to win here. To win here, you got to have access to the claims data and know what to do with it and how to clean it up. So we had about $4 million of investment that we have open sourced. And then the nice thing is, there's all these incredible people in the industry that want to have the right thing. And once they understand, like, okay, you're saying that, people call me all the time, how did you do this? How did you do that? And they don't have unlimited time. Maybe if it's a governor, they're going to answer their call. They'll say, you mean if I pour my intellectual property in here, you'll organize it and you will make sense out of it and you'll make it available for free and I can just point people there? Yes. So you have these people who've been doing it 10, 20 years who are creating this virtuous cycle. That is all radically different than anything I've ever seen in healthcare, and particularly on the health plan side. And, I always remind people, like, we didn't get smartphones by tweaking the landline and rotary phone supply chains. You always have to develop a new supply chain. We have this regulatory shift that's big. We have a generational shift, right? The 70% of the workforce are millennials and Gen Z. The oldest millennials, mid-40s. We have plans that were designed when boomers and the greatest generation, and acute care was the main issue. Now it's chronic disease, it's mental health. So we're overdue for one of these once every 50 to 70 year shifts. So all those things are converging right now. And you don't have to believe me. We put it out there, talk to the people directly without us, and, judge for yourself.
Yeah, your point about the generational shifts and the transitions is a good one that many people, as simple as it sounds, don't really appreciate the ramifications from that. And we're certainly seeing that playing out in Washington right now, which helps move some of the things you're talking about along. Steve, do you want to add anything further?
Yeah, I'd say that one of the interesting pieces, and I guess you asked, why are we going to be successful here, is that this whole issue of fiduciary responsibility and compliance. Dave likes to say that this is the only area where you can spend money on compliance and get a significant ROI from it. And I think the ability to deliver that message to some executives who probably haven't been that involved in their HR benefits, but if we can get to the board, board directors, CEOs, CFOs, and say, there's a couple of things that we're doing. We're taking compliance risk off the table. Great. Many might not think that they're going to be sued. I'm not JP Morgan, whatever, but hey, we're going to help you do the right thing. And if you do that, you're going to get an ROI. You're absolutely going to save money on your pharmacy benefits. You're going to save money on DPC. You're going to save money on direct contracting. You're definitely going to save money on imaging and some of the things that are shoppable and that you can buy. And so that combination, it's kind of like chocolate and peanut butter, right? It's they're each awesome, but you bring them together and you've got something pretty different. And we're also starting to get some people, making some noise in that direction. And one that I'll mention is, that's highly supportive of what we're doing is Mark Cuban. And he's focused on this area for a reason, right? And he's calling out CEOs and saying you have to pay attention to this area. And this is, a good thing to do. And if you do, you're going to get big benefits. And so I think that's different than, some of the things that have been done in the past. And, healthcare is kind of like a Gordian knot. You have to figure out what's the right string to cut. I think we found the right string to cut.
Yeah, if I can just give you one example, from a conversation with a CFO that, mid-market employer, by the way, 2/3 of employment is in companies, under 10,000. And that's really where the action is in mid-market. So this is a 700-person, 130-year-old company, manufacturing, recycling company. And they got smart on all this. To Steve's point, the more compliant you are, the more it helps their business. A decade ago, they're spending $8 million on their health plan. Their peers now are spending $12 million. The last 4 years, they've been spending $3.5 to $4 million. I asked the CFO, what would you have had to do with top line sales revenue to have that same EBITDA impact? And he's like, yeah, it would have had to go up 25 to 30%. That's pretty tough for a 130-year-old company. And they happen to be an employee stock owned company. So the nest eggs of those employees doubled because of what they did in their healthcare. That gets some people's attention and really cements this change. So, some carrier could go in there and try to we'll make it free in air quotes, now this is game changing for our business. There was a forklift driver who retired. He'd been making $45K a year, got a 7-figure payout, right? He had a pretty good payout because of employee stock owned, but doubled. How many forklift drivers are retiring with 7-figure retirement packages? That's what's possible here.
That reminds me of some of the good stories coming out in the late 90s, early 2000, some one-off work, which I think to your earlier points that you both made, there's been a lot of one-off successes, but how do you really coalesce and gain some momentum? The mid-market clearly is where the action is. The other one that gets some attention that a lot of people don't talk about, and you've kind of touched on it a little bit, is the unions. Where does the union factor into this? Because I don't think anybody realizes that unions aren't that much different in some ways, but are different in other ways to the commercial employer plans.
I mean, they are kind of paralleling employers where a lot are, frankly, been asleep at the wheel. And sort of conventional thinking is, they're spending more money, therefore we won, and therefore we have a bigger, better plan. The smart ones, and increasingly employers are saying, hey, here's this pot of money. You can split it however you want between payroll and benefits. That's up to you. And so one of those first successes that I wrote about in my first book, it was 45,000 members union, and if you go into their meetings around health benefits, it's literally 50-50 labor management. And if you went in there and you watching the people who were really pushing for more benefits, we need to get rid of UPMC out of the network. Yeah, they have a great brand, but on most things, they're low value. It's actually the union people who are doing that. You might think it's management. And so some of the greatest successes, like an SEIU union in New York that for the real estate market, 32BJ, they did one thing. They've done a few things, but one thing they did was they removed New York Presbyterian from the network because they're low value. That immediately meant $30 million more in the union. It led to an unprecedented one-time bonus, the biggest raise in contract history. And again, getting access to the data has been a big part of that. And then you just think about like the apex events in a health plan, a pregnancy, right? You now have people like my niece works for a health system. This is kind of sad. She had to go under her husband's UPS plan to have a good, kind of maternal coverage. Whereas at 32BJ, it's $40, 40 all in for the entire maternal journey, the whole pregnancy, birth, you name it. That gets people's attention. They become the biggest advocates once they dig in and realize, oh my gosh, our teachers' pay and class sizes and benefits is more important than the third vacation home for the UPMC exec.
One of the other concepts that you've talked about as you start to eliminate the waste and improve the functions and the structure of these benefit plans and operations, and others have validated exactly what you're talking about as well. But there was another trend that I've seen as well over the last 10, 15 years, which is around the concept of how communities do a better job of controlling their own care. So what are your thoughts around that, and where are you trying to go on a more of a local healthcare concept basis?
Yeah, I mean, that is, our vision is what we call community-owned health plans are available everywhere. And so I'll just bring it back to home for my own, I'll give you an example. Ashtabula, Ohio. They're a good example of this, where very challenged, kind of stereotypical Midwest community, about 100,000 folks. And, we all know that the Midwest has been hit, a lot of plant closures. And if you go back to when NAFTA happened, a lot of companies, rather than solve the root cause of the issue, like, we're just going to ship jobs out of our country rather than solve the root cause. And communities like Ashtabula really got devastated, but there's people who really care there, and it's a single hospital town. And, it just started with a single employer, 38 employees. Like, this isn't even a mid-market employer. I think it was a auto dealer or chemical company. The real game changer was when the school district, eighth poorest school district in the state, they're getting hit like everybody else. And even though it was outside of the collective bargaining agreement, so there was definitely some hands tied. What you can do is add new things outside of the collective bargaining agreement. They said, hey, we're going to add great primary care. Hey, if you go to the best surgeons and the best surgical facilities, yep, it's an hour away, but you're going to pay exactly zero versus having these sky-high deductibles. And the famous healthcare system near them, like they're great in cardiology, they're great marketers. They have some of the worst outcomes for musculoskeletal, which is often 20% of spend is around musculoskeletal procedures. And they put in this new plan July of 2020, even though it is a very challenged community, generally they would pass school levies. But in May 2021, not even a year later, school levy failed. Small school district, like 300 staff. Normally devastation, cut teachers, benefits, transportation, extracurriculars. Even in that short amount of time, they'd saved more money than the entire school levy. It literally saved the schools. And the city manager, his wife worked as a teacher, wow, we want that. So then the city did it. Then the county did it. And now there's these private sector employers who are thinking, gosh, I thought we were smarter than public sector employers. We got to get with the bandwagon here. And the thing is, that local level, we all know word of mouth is the best marketing there is, the best content, and word of mouth is successes. And we know, industries that want to protect status quo, the classic strategy is use fear, uncertainty, and doubt to freeze things. And it's really easy to use, we call it FUD in this industry. Well, it stops working when people can see it with their own eyes. And so it's just become almost like you go to some communities, there's Kaiser Permanente, it's not in other communities. It's just another valid option. That's kind of what these high performance Health Rosetta style plans are. And so that's really cementing it. And then there's, a longer term theory of change that says, why should this be limited to employers, right? We got a while to get there, but this becomes a really foundational thing where a community like that is having for a fundamentally local service, they're probably having $450 million extracted out of their local economy for just a 100,000 person community. And I call it economic development 3.0, right? Where you stop that. I mean, what's more local than an interaction between an individual and the pharmacist or a nurse or a doctor? We haven't thought about shop local in healthcare, but that's what's happening. And it's really powerful and gets this virtuous cycle going. And people are building confidence where they didn't have before. And, imagine all these needs that exist in the community where 90% of our spending on health goes to healthcare, sick care, whatever you want to call it, even though it only drives 10 or 20% of health outcomes. That's the idea of turn that waste into prosperity and let the community decide, right? To our earlier discussion, the cavalry's not coming from DC to save our communities. It's on us. And more that's happening.
Here you talk about the model and the idea and the success that came out of it. It reminds me of what I remember growing up and what it was like in the 50s, 60s, even early 70s. And, when I think about what's happened over the last 30, 40 years and the change in the infrastructure and the complexity within the healthcare ecosystem, people like Steve and I that have been involved with consulting and work with employers. I mean, a lot of our time is really about how do we simplify this mess as opposed to what we thought we'd be doing around, simple advising and how do you place a contract and have it actually work for you. So Steve, what's your observation of what Dave's talking about?
Yeah, well, I was going to build on Dave's last comment about, some of the fair trade and local sourcing. And, one area where that desperately needs that is the pharmacy area. And a lot of these traditional PBM contracts have focused on steering and in particular as they've integrated, right, they're steering it to their own pharmacies and away from locals and independents, and there's definitely a room for mail order and those kinds of things, but having a focus on the local community and having your PBM contract actually pay a fair reimbursement to a local pharmacy and to have a pharmacist more closely integrated into your care management processes. And, Dave talked earlier about navigators and, clinical navigators and those kinds of things, to have a pharmacist, be, a part of that and be looking at drug interactions and be looking at drug efficacy and making sure that, again, you're got the right instructions and, a huge amount, huge being, probably like more than 50% of patient admissions into the hospital have to do with poor adherence to their drugs. And so make sure people are getting the right drugs, make sure they're taking the right drugs, making sure that they're reordering, those drugs have a huge impact. And so, again, part of what we're trying to do is to make sure that local employers are not contributing to the demise of a vibrant provider community, which includes pharmacists.
Yeah, I mean, and I just add in Ashtabula, Maria Fowler owns Hoffman's Pharmacy, independent community pharmacists. They are the preferred pharmacy, and they are incredibly valuable in that. And I asked Maria, I was like, what's the difference? You have somebody who's on this plan versus another. And she said, there's always issues that come up. And even, in our world, we're not perfect, right? There can be some glitch. Like over in this world, this new world, we can get a human on the phone to resolve an issue. You can't do that with the big PBMs. You just get this runaround. And so her hands are tied to provide the best care and best guidance to her patients. And, that's really demoralizing to somebody who's been called to serve people in a clinical role. So that human impact is really big. And the clinical impact, of course, is massive.
Yeah, another question around the kind of the patient impact, because that's a lot of what we've been kind of talking around is how do we solve some of these issues for patients? We've all had our own stories, as both of you have identified, that kind of drove us into how do we really get to system change. But Steve, what's the biggest thing that we're still getting wrong about patient access or the employer involvement around their members who are their workers that are the patients?
Yeah, well, patient access, I guess is a broad term, but if you defined it as, access to the right drugs at the right time, as an example, restrictive formularies would be on the top of that list. We talked just briefly about all the mischaracterization that goes on where thousands of generics are being mischaracterized as specialties so that they can basically make more money on it, right, without having a specialty. And then you have the restrictions that you mentioned, earlier, where only a certain amount of drugs are on the formulary, and it's primarily because they have the highest rebates. And highest rebates drive higher costs, and the people that are actually paying for that are your sickest employees, typically, right, through these high deductible health plans where they've got anywhere from $1,500 to $5,000 in the deductible. Well, that's going often to these really high cost drugs, right? And so if we can move away from rebates, and we probably can't move away from all of them, but if we can move away from most of them, have a focus on lowest net cost, not highest rebate or highest discount, and make those tiers go away, for the most part, as Dave said. It's interesting that drugs are generally well controlled through the physician. Not always, and there has to be some checks and balances, and particularly when you get to the highest, most expensive specialty drugs, you want to have a prior authorization. But for the most part, there's no reason to have tiers and deductibles for the vast majority of generics. They're really cheap and are highly effective. And so that massively improves access. And then you can focus on those drugs that are really high cost. And that's one of the big areas today, right, is autoimmune conditions, cancer, HIV. A lot of the drugs that are coming out are hundreds of thousands of dollars a year. And so you need to make sure that, they work, because they don't all, right? Just because they have been approved by the FDA doesn't mean that they're actually high efficacy. So let's make sure that you're using the best drug at the lowest cost and maximizing that benefit for employees. And then, we've got a comparable issue around biosimilars now, which are, there's a lot going on biosimilars. There's, for Stellaris, there's 6 or 7 biosimilars that are out there. The big PBMs are trying to control them. I think someone mentioned earlier, maybe Michael, about they're getting into the manufacturing business. Again, they're trying to control the whole chain. But if you have a good biosimilar strategy, you literally need to do that drug by drug, therapeutic class by class, but you can, really dramatically improve access and cost that way. And then, the final one that I'll touch on are GLP-1s, and it's really sticky, right? And there's all sorts of, new evidence around, how well do they work, and how long should you be on them, and, those kinds of things. But there's a lot of demand for them. There's a lot of benefit from them, but you really need a, kind of a strategic approach to it. And so if you can optimize around that, then you can improve access to those drugs as well. And so all of those things, the last thing I'll say are P&T committees, right? The committees that most PBMs have that are choosing, what drugs are on the formulary. And generally they are, looking at margin-driven choices, not efficacy-driven choices. And you as an employer need to make sure that you've got some say, you've got some visibility, and maybe you even have a veto, right? And say, I don't want that drug, I want this drug, and maybe that has some implications on my rebates or my costs, but I'm willing to do that to, get the best access. And so, having a measure of control in your process will improve access.
The other thing that we touched on during the conversation is your multi-year experience with the RosettaFest, which is in Denver this year, later August. So can you give us some insight as to what's the vision for this year and then for this event, and who should attend?
The who should attend is what actually makes it unique. You have most healthcare events tend to be very siloed. You got your orthopedic surgeons, or you got your health tech, or you got your PTs. This is a team sport. And so we have about 1,000 people come, pretty evenly split between the real payers of healthcare, employers and unions. So the people who've actually been doing this, we've been talking about it. And a big theme of the event is celebrating the best health plans in America. And so there's awards that are given out around that. And these people are open book in their public sector, their private sector, all different sizes. Bucket 2 is basically the people who, we were talking about these benefit consultants, advisors, brokers, like they're the tip of the spear, like they're the ones going out into corporate America, and the best of them, deliver incredible value. Bucket 3 is the clinicians, mostly physicians, and a real big group of primary care, particularly direct primary care, but a lot of direct specialty care. And they're really the ones that there's a new healthcare economy that's emerged. It's already bigger than the US video game industry or textile industries. Like compared to 5 trillion, nothing's big, right? But it's actually a big industry. We're talking 30 to $50 billion. We can't do it without them. And then the fourth bucket is, we've been talking about PBMs, TPAs, right? The solutions, the tech that are really a key part of that. And we come together around that. And then the big theme, which we've been talking about, the nonprofit that we catalyzed with the $4 million of open source, procurement, contracting, data use, data platform, that's called Nautilus Health Institute. And so Steve alluded to one of the big new sort of tools, resources is this PBM field guide, right? It is the kind of granddaddy of them all in terms of shenanigans in the status quo. And so the field guide gives you the tools, educates you, as he said, but we're rolling this out and people are starting to get it. Because again, what we're doing is pretty countercultural to the way healthcare is normally operated. And when we rolled out this technology that basically allows you to ingest the claims data, the medical claims, the pharmacy claims, and know what to do with it. We've just launched it. We have a limited beta because we have limited resources right now. But there's 7 companies in production. There's another 20 in evaluation. And we're moving basically about $3 million of investment for maybe you've got some diabetes solution, you've got some, autoimmune condition. It's this plumbing level you have to invest to actually prove your things out that doesn't differentiate. And so that we're starting to educate on this. And so we're really excited about, there's people like Steve who are project managers, and then there's subject matter experts who are also a big part of this. And then there's people who go carry it out in the market. So we're doing a lot around that because we really feel, as we talked about earlier, this industry is in this inflection point. Like we've all heard forever, isn't sustainable. We've wondered if the industry would ever change. Of course, we'd all like it to happen faster, but it's finally happening. And so that's a big theme of the event.
Well, I can tell you, I definitely have to go to this. So I'm going to register.
Dave, I got to tell you, I'm writing the forward to the PBM field guide as we speak, and I'm going to have to put PBMs are the granddaddy of shenanigans, right?
You heard it here first on the Only Healthcare podcast.
Yeah, you sure did. But you just wrote the forward for us. Thanks.
Yeah, and that's the first time I've said that. It just kind of came to me. So yeah, you got a scoop here.
This has been amazing, by the way, and congratulations on all the successes and the strides you guys are making, because it's really tremendous and it's what people need to hear about, really.
We get our teeth kicked in every day. This is not easy work, but it's incredibly rewarding. And that's the beauty. Like we know we're working on this 20, 30 year long problem, but back to that patient access, the day one of these plans goes live, these teachers, these convenience store clerks, manufacturers, it's like they're getting a raise because they show up to the pharmacy and they no longer have to pay $300 a month. If you're making $12 an hour as a convenience store worker, it's life-changing for them. So that's what keeps us going, is you have all these little wins that are really just compounding on themselves. And I think that's the biggest vibe difference that people have when they go to RosettaFest. It's like, wow, we're actually winning here. I actually have hope. Somebody called me a merchant of hope. I'm like, okay, call me whatever you want. But you can actually see it with your own eyes. It's hard not to be hopeful.
There's a lot of history that supports a lot of what you're talking about, as you said, and probably we are at the right time, this inflection point that you refer to. Michael's been kind of involved in some other things related to that as well.
You guys had mentioned Mark Cuban, so he's on our platform, because what we do is we aggregate a bunch of cash cards and then we integrate the members' insurance. And when we do that, Mark doesn't love this, but only about 10% of the time he's cheaper than anybody else. But he's doing the right things, right? It's not that he's not out there to be the cheapest, but he's out there to show the transparency and the opportunity.
He's been super helpful to this, and he's kind of joined this open source thing. One of the things he's doing around the RosettaFest time is open sourcing, because he's an employer too, right? All these employees doing obviously he had the Mavericks before, but then the whole cost plus drugs, and he's open sourcing the hospital contracts, which is probably, one of the top 3 contracts, right? TPA, PBM, hospital. And so I don't know, I think we had some influence on that, and there's more and more people going, wow, this is actually a pretty cool idea of doing that we can actually change things. So we love his voice. He's got a big platform. Yeah. So all good. Even though, there was other people doing what he was doing, they just didn't have his platform.
Well, this has really been great, and I'm glad we're able to get the 4 of us together today. And for our audience, and kind of closing this out, if today's conversation resonated with you, we need your voice in this movement, and join what we're all trying to do in our various ways, and how we're working collectively as well. The U.S. healthcare system isn't going to fix itself, as we've been talking about. But if we're working together, we have some collaboration, we have accountability and informed action, we can actually rebuild it for everyone and have a more positive outcome. So thanks for tuning in to the Only Healthcare podcast, and please follow us and share with others that you know.
Thank you for tuning in to the Only Healthcare podcast. We hope you found today's episode insightful and informative. Remember, our mission is to provide actionable and inspirational insights on how we can improve healthcare cost, care, and accessibility for all. If you enjoyed this episode, please subscribe, rate, and share with your friends and family. For more resources and updates, visit us at onlyhealthcarepodcast.com. We'd love to hear from you. Let us know what topics you'd like us to discuss in future episodes. Until next time, stay informed, and together, let's navigate the journey to better healthcare.